We're assembling here today with an expectation of making some personal progress in understanding and perhaps in effecting a small change in what we all realize is a very complicated system that addresses terribly important issues for us, our families, the general society. The health sector is 16% of the economy, and it's continuously increasing and troublesome in many ways. And there's a general perception in our society that compared to others, that we don't have consistently better or even sometimes as good outcomes as other countries, despite the greater resources we allocate to health. Now, these outcomes may be medical parameters like lifespan, infant mortality, cancer survival, or they may be what I'm calling satisfaction parameters, such as access to care, value for cost, retaining personalized services. It's debatable as to whether the U.S. really underperforms by any of these parameters, regardless of the per capita expenditures. However, there are agendized critics and non-objective media who reinforce the perception that all is not well. And our political opposition blames it on us and uses it for political gain. And if you've been listening to the debates, you know what I mean. The degree of dissatisfaction by various parties with many major components of the healthcare system and by many of its most important players creates a minefield of potential disasters whenever someone attempts to alter the system, hoping to improve it. So we must tread carefully, if not lightly. And the reality is that we do spend more money per capita than any other system because our citizens demand unhindered and rapid access to the latest technologies, regardless of their age or infirmity, or their ability to pay. And they do not want a rationing of resources, as in other countries. People want the CAT scan or the MRI in 6 days, not 6 months, as in Canada, with a health provider of their choice. And this is really important, because this message doesn't get out. Someone who makes choices with them. And this cannot be provided on the cheap. And as you can see from this graph, that when you ask people who they want to help make those important decisions, overwhelmingly, they want their physician to make those choices. They do not want a bureaucrat to make those choices. So this problem, it not being on the cheap, it's compounded by several fixed drivers of cost. First, we have the demographic. We have a baby boomer generation, population bulge, and an increasing lifespan. And along with that, we have an attitude of entitlement and expectation. Just think about that. Baby boomers, more older people wanting everything. And then we have a technologic driver, increasingly sophisticated and expensive tools for diagnosis and treatment, which never before existed. We can diagnose diseases earlier and more often and proceed to treat disorders that were never treated before and with tools that never existed. This creates a huge burden of cost through expectation and demand. And then downstream, it creates issues of access, affordability, and individual satisfaction. Another dilemma is the concentration of healthcare spending in our society. If you look at this graph, you'll see 10% of the population accounts for 64% of the spending on healthcare. 1% of the population uses 22.5% of the resources. And the healthy 50%, they only use 3%. So this makes it really difficult to create an insurance system where the majority of the society perceives the expense as reasonable for the probable benefit. 50% of the people are only using 3%. And that's one of the issues about why the insurance is such a problem. This makes people not want to participate in an insurance system which shifts costs so markedly. And consequently, we have large numbers of non-participants, regardless of the legislative intent. Massachusetts being the latest example, where it didn't work. And Ralph Weber is on our panel, next to me. He's an expert on health systems and risk management and health insurance. And he's going to be talking about these issues and give us some guidelines for reforming the system. If we acknowledge these worrisome challenges of cost and affordability and insurability, we can move on to the issues about how to deliver all of this increasingly more unaffordable care. And that brings us to the dominating national issue of centralized or one-payer socialized care, as in the military or the Veterans Administration, or like Canada, with ration care, which forbids the private alternative completely. Most people don't know that. There's no private alternative in Canada. Versus individualized fee-for-service care, where there are lots of options and choices for consumers. And then we have some hybrid models, like Kaiser and HMOs. So these choices require very difficult decision-making by the society collectively, as well as by the employer and the individual. So it's important that we develop systems to minimize the waste and fraud and abuse, but it's crucially important to make sure that the care that is rendered is of the highest possible quality, and by practitioners who are expert and caring, motivated, so they can perform as best possible. And this alone necessitates an ethical and medical legal infrastructure which is very complex, introduces major vested interests, inherently jeopardizes patient advocacy, with doctors receiving a progressively smaller percentage of their revenue directly from patients. It is becoming less possible for them to advocate for their patients with insurance companies who now pay most of the bills. And back in those early days, doctors got most of their money from their patients so they could make decisions based upon what the patient wanted. They can't do that anymore. They get their money, they get their orders from insurance companies. That's a real problem. This is why consumer-driven free market healthcare has been so weakened and where the opportunity to rebound survives. And Dr. Marcy Zelling is an expert on an alternative model of primary healthcare. She'll be expanding on it. Physician advocacy for patients has been markedly compromised in this era of corporate medicine. Huge and powerful hospital conglomerates controlling health insurance networks who set the fees. The doctors don't set the fees. And not only do these powerful interests set the rates and the reimbursements and determine the utilization of beds and meds and high tech, but these players and payers limit doctor advocacy, which includes reporting compromises of care. When physicians complain about quality issues, they put their privileges at risk and their licenses and their careers. Sham peer review is a real problem, and the battlefield is now littered with hundreds of physician casualties. Government bureaucracies and state medical boards are intrinsic to the problem, and they're often politicized. And there's a lot of controversy about this issue, important work to be done, most of which is under the radar screen of the public. Effective whistleblower legislation is needed. Dr. Milikowski is very involved in these issues. He'll be talking about these issues and the legislation that's been proposed. Now, this leads to a discussion of the final challenge of our agenda, the balancing of the need for legislative initiative and mandates versus allowing the free market system to work and promote efficiency and individuality. And the centralization of decision-making, facility planning, provider allocation, pharmaceutical formularies and prices do not expand patients' choices. Assemblyman Nakanishi will clarify and differentiate the Republican and Democrat California positions and the initiatives on health legislation. Our panelists today, drawing upon their training, experience, and diversity, will attempt to educate us within this framework of compelling forces and urgent needs. And their job is to expound on their area of expertise, challenge their colleagues' positions, give directions for changes to the system, and then we'll give everyone an opportunity to bring forth their questions and comments. And thank you for your attention. So, Ralph, I'm going to turn it over to you now.